hospitals. Today we are going to know about a very important cancer which has increased in incidence in India due to various reasons in the recent past, and this is very important cancer for which awareness is needed in the society. That is colorectal cancers. Colorectal cancers are the cancers that occur in the large intestine and in the rectum. Cancers that occur in the large intestine and the rectum are called colorectal cancers. And why these colorectal cancers happen? Either whether a male patient or a female patient, who is more preponderant, and what are all the dietary habits, what are all the risk factors, we will come to know about the colorectal cancer risk factors now. So initially, to start with, we'll take about the risk factors. Risk factors like low physical activity, diabetic patients, smoking, alcoholism, and obesity. Obesity itself is a risk factor. And certain other risk factors like high intake of red meat and low intake of vegetables and fruits. This is very, very important to balance in the lifestyle of a society. So the modification of these risk factors, what are all the risk factors I mentioned? These risk factors are modifiable risk factors. If you want, we can culture a positive, healthy style or a healthy lifestyle and cut off all the negative risk factors. And the two more important things I need to mention. One is the familial inheritance of colorectal cancer, and the other one is there won't be any reason. De novo occurrence of colorectal cancer. So certain modifiable risk factors, de novo incidence, that means there won't be any clear-cut risk factor, but the patient develops colorectal cancer. And the other thing is familial incidence. So familial incidence of colorectal cancer can't be modified. And this de novo incidence can't be modified. These are non-modifiable risk factors. Now, for example, a patient developed colorectal cancer. With what symptoms he will come to the concerned doctor? Initially, he may present with blood in the stool, bowel habit alteration of bowel habit. Frequently, he will be having constipation, diarrhea, constipation altered with diarrhea, like this. And in some patients, we notice spurious diarrhea. What is this spurious diarrhea? Patient actually thinks he is having diarrhea, but it is not actually the diarrhea. He will be passing small amount of stools multiple times. This is called spurious diarrhea. And in some patients, we notice loss of weight. And certain patients, we notice distension of the abdomen. We get the obstruction. And fall in the hemoglobin, patient developing anemia, and certain patients developing vomiting. So these are all the symptoms which I mentioned. To brief, blood in the stool, alteration in the bowel habit, spurious diarrhea, fall in the hemoglobin, distension of abdomen, and certain patients having vomitings. These kind of symptoms, when a patient or when a normal person they are having, means they should consult immediately the concerned consultant, concerned specialist. So when you consult, so most of the times, the patients with these kind of symptoms meet the nearby medical gastroenterologists. So medical gastroenterologist, what he will do is he will do a colonoscopy. He will do a colonoscopy and examine an entire large intestine and the rectum. Suppose if a growth or if a bulge is seen in the large intestine or in the rectum, he will take a small piece of a tumor as a biopsy. That will be sent to the lab, histopath lab, pathology lab. And from there, we'll get the diagnosis, whether it is a cancer, whether it is not a cancer, then what it is, all these findings will be known. So these are the basic symptoms with which most of the patients with colorectal cancer meet the consultant nearby. So what is the role of surgical oncologist here? So most of the time, as a surgical oncologist, will be, as a tertiary consultant, will be receiving the referrals from other doctors. So when the patient comes to us, the patient might have been already worked up, like colonoscopy biopsy already done. Once the colonoscopy biopsy is already done, what is needed to be evaluated? What are all the things needed to evaluate the patient, to decide what treatment he is going to land on? So as soon as we see the patient with a colonoscopy biopsy proof of malignancy, we generally clinically examine the patient. We examine entire abdomen and we do rectal examination. Suppose if growth is felt, what is the extent of the growth? What is the distance of the growth from the anal verge? Is it mobile or not mobile, or restricted mobility, sometimes tethering? All these findings are very important in deciding further line of management for a colorectal cancer patient. Once we finish up this clinical examination part, that is, examining the abdomen and the rectal examination, then we order an imaging investigation. Most of the times, for a coronary cancer, the contrast-enhanced CT scan abdomen and pelvis is enough. And for a rectal cancer, MRI pelvis with contrast is enough. But if we suspect metastasis, or if we suspect a locally advanced disease, sometimes we prefer to choose whole body PET-CT. This whole body PET-CT identifies any lung mets, liver mets. Liver mets can be identified in CT scan or MRI also. So complete evaluation. So a patient is, now we discussed about the risk factors, what are the symptoms they present, and initial evaluation and imaging. Once this imaging is done, now we divide 3 sets of patients. Let us assume one patient with a confined growth in the colon. And this patient is not having any spread to liver or lung, and the disease is confined to the colon. This patient is a surgical candidate. This patient will go for surgery. This surgery, most of the times, will be done in 3 ways. One is open method, second is laparoscopic, third is robotic. Laparoscopic and robotic are minimal invasive approaches, and open method is an invasive approach, maximally invasive approach. So the method of surgery, the outcome of surgery, long-term outcomes are same, but initial recovery and the mobility and motility will be very good with laparoscopy and robotics. And for colonic procedures, especially colonic cancers, laparoscopy and robotics advantage is the same. So it is, suppose if the cost issue is there, it is better to give an option of laparoscopic approach in the case of colonic cancers. So this is the surgical procedure is, we do hemicolectomies like that. So surgical options of a cancer in the colon I discussed now. I will discuss another option. Suppose the patient is having the growth in the rectum, rectal cancer, and it is a confined disease. It didn't spread to liver or lung. It's confined and it is high in the rectum. Then the patient again becomes a surgical candidate. The same disease can be operated with 3 approaches. That is again open, laparoscopy and robotics. Suppose if we come to the rectum, especially I just mentioned it's upper rectal growth. Upper rectal growth, again the laparoscopy and robotics has the same advantage. But suppose if the growth is lower down and we are going to do a sphincter preserving surgery, and we are not putting any permanent stoma in in that patient, the role of robotics is huge compared to laparoscopy. So the concern of robotics is the cost, and we are doing affordable packages because in our hospital, and all of the patients are getting benefited. So rectal cancer management, the colonic cancer management, it varies sometimes, but most of the times they are clubbed. In the case of investigations wise, in the case of surgical approaches wise, all these things. So in the case of low rectal cancer, suppose if the growth is bulky and if it is going into the outer layers, then we don't operate. We send the patient for preoperative chemoradiation. So this is the second set of the group. Let us assume now the third set of the patient. I told two sets. One growth is operable in the colon and the other one is in the rectum. And third group is, suppose the patient is having a colonic growth or rectal growth and the patient is having liver mets. Disease has gone to the liver. So suppose if the patient is having a single metastasis in the liver, this patient can be operated. But multiple liver mets, there is no chance of surgery. The patient will be going for palliative chemotherapy. And so these are all the different sets of patients I would like to tell. So the approaches like open laparoscopy and robotics, all these three are equally good, but the advantage with robotics is early mobility and early mortality. Now, we would like to take, suppose the patient is having locally advanced disease. In the case of colon. So locally advanced disease in rectum, what did I tell? If the patient will go for pre-operative chemoradiation. So suppose the same situation is in the colon, then again we may have to operate the patient. The chances of giving the neoadjuvant chemotherapy in the case of colonic cancer is not that useful. So this is the way, first what the symptoms they present, how we evaluate the patient, and how we divide the patients according to the situation, and what kind of treatments we give. So what is the role of chemoradiation in the case of colonic cancer? Now we will divide colonic and rectal cancers. What is the role of chemoradiation in the case of colonic cancer? So in the case of colonic cancer, we are not irradiating any patient. All the patients, most of the patients will be receiving chemotherapy after surgery. And as I already mentioned, there is a definite role of chemoradiation in the case of rectal cancer, either before surgery or after surgery. It is based on the extent of the growth in the rectum. Suppose if it is going to the outer layers, we give chemoradiation followed by surgery. Suppose if we operate and any lymph node positive disease is there and thickness is a little bit more, those patients will be needing chemoradiation after surgery period. So most of the patients, in the case of colorectal cancers, we will not be putting the temporary stoma. Most of the patients will try to avoid stoma, but there are certain patients in whom a temporary stoma has to be done. For example, in the case of a coloanal anastomosis or post-chemoradiation treatment rectal cancers, if we are opting for a low anterior resection, in these patients, we put the intestine outside for a temporary time. That is only 3 weeks, 3 to 4 weeks. After that, that stoma will be closed. So these are all different concepts of colonic cancer and rectal cancers. What is the role of surgery? What is the role of chemoradiation? What is the role of chemotherapy? So the chemotherapy, after suppose we operated a patient, in the case of rectal cancer, there is node positive and outer layers are involved in the biopsy, then the patient may need, after chemoradiation, chemotherapy also 6 cycles. So the integrated treatment of surgery, chemoradiation, and chemotherapy is the mainstay of our main line of management in the case of colorectal cancers. Now, how to prevent colorectal cancers? These are all the investigations, line of management, and other options of treatment, and the role of robotic surgery in the case of rectal cancers. And lastly, to complete the information regarding colorectal cancer, how to prevent a colorectal cancers. So sometimes a patient with familial incidents, family history, significant family history, may undergo a prophylactic colectomy or rectal proctocolectomy also sometimes to prevent the disease in the future. And certain studies are showing the NSAID intake, aspirin intake, and vitamin D intake is reducing the incidence of cancer in the case of polyps in the oral and rectum. So these are helpful in prevention of colorectal cancer. As I already mentioned, the modification of risk factors like smoking, alcoholism, physical activity, obesity, and the dietary intake, high vegetables, high fruit intake, and low red meat intake, all these things are going to modify the incidence of colorectal cancer. And these are all things can be taken care of in the prevention of colorectal cancer. So from the beginning till now, what all we discussed is regarding the lifestyle only. So what is the main conclusion here is that colorectal cancer is a lifestyle-based disease. So if we modify the lifestyle in a healthy way and maintain a healthy lifestyle, colorectal cancers can be prevented. I can't say all colorectal cancers can be prevented, but to a certain extent we can prevent them. And this de novo incidence of colorectal cancer plays a significant role in the case of incidence of colorectal cancer. That we cannot modify. So, better lifestyle, better future, we can prevent the occurrence of colorectal cancer. So, have a healthy lifestyle. Thank you.